treat fish.
Ew, it's weird to hear.
Okay,
No, I just watched.
We can't fix that page out.
I watched it like twice a week, probably.
All right, good morning, everybody.
Good morning.
We're gonna get started on time today. Hopefully we'll finish on time. Dr. Brainerd is ill today. He's got some kind of sinus problem. And so he won't be here. So I'm filling in. And before we get started, I wanted to mention that there is another case attached to the material. I don't know if Dr. Brainerd mentioned it to you or not. I mentioned it to one of the students to look at it. This is very useful for you to go through and look at because it explains all the kind of things that are going on in this case. This was a patient that we did in the past. We called him Henry Tolliver, and that just stood for hypertension. Art Fisher stood for atrial fibrillation. Renee A. Smith stood for So this particular patient has the same problem that our patient has today, and that is an aldosterone-driven hypertension. But this particular patient was somebody who was at the VA Medical Center, and he was seeing several different doctors, but he wasn't telling any of the doctors that he was seeing other doctors. And so they were prescribing medications for him that would treat hypertension. And what he had was an aldosterone secreting tumor. And the only medication that he was on, these are all his medications. To treat hypertension that he wasn't on was an aldosterone antagonist, which is really the only one that really completely helped him. Now he ended up having his adrenal gland resected that had the aldosterone secreting tumor, and he was fine. But he went on for years with this hypertension problem with all these different treatments. The value of this case for you is looking at all these various drugs and how they work, what they do, how are they trying to accomplish treating hypertension. It gets into all the mechanisms about things that we're trying to learn about. For example, if I can remember these things, this was actually an anticoagulant that he needed just because with hypertension you get sometimes clotting problems because of the blood is moving so fast and spinning through vessels and creating turbulence. So this was an angiotensin II receptor antagonist, which would be helpful if he's got angiotensin II, which he does, because, well, he didn't. Okay, so he was aldosterone directly stimulated, and so his angiotensin was suppressed. But he was on all these things: angiotensin receptor blocker, converting enzyme inhibitor, calcium channel blocker, beta blocker, smooth muscle relaxant. Our patient was on this, hydralazine, the hydrochlorothiazide. She was also on that.
At this time, could we look at a chart to be able to tell if they're going to other doctors?
Pardon me?
At this point, couldn't we look at a chart and see if they're going to other doctors? Because if they're on all these drugs, somebody prescribed.
Well, I don't know how it happened. This patient was seen at the university because the university takes care of some of the patients at VA. But he was going to the VA, going to the university, and going to an outside doctor all at the same time. And they weren't aware of each other because they don't have each other's information. So he then wasn't mentioning that he had already had this and that. And they didn't. You know, it was a really big mix-up. It wasn't really the best situation. So the Lasix is a loop diuretic that's real powerful. Clonidine is a central inhibitor. It's an alpha-adrenergic blocker. So you can see when you read what those things are, you can imagine what the mechanisms are they're trying to attack. But if you still have a volume expansion hypertension due to aldosterone, those things can be helpful, but they're not going to cure the problem. So they took out his problem adrenal gland. I can't remember which side it was. Left the other one, and he was fine after that. So read through this material because it's set up in a way to help you look at all of the different mechanisms that are in play with each of the different drugs and what they're trying to accomplish. I can't think of a better way to get a quick understanding of how all this works than to go through that case and read all those materials. Enough said about that. So let's get started with what we've got today. And we'll just go through the questions in order that they are and see what you guys have to say about it.
But you, yes, I am.
Make sure we don't X out the Google Chrome page, because Dr. Brainerd left himself logged in. That's the only reason we were able to get back in his account, and I don't know if it'll stay if we exit.
Oh, wait, well, I need to log into my
Just like
account.
move tab.
Okay.
Like just don't exit the one out and stuff.
Okay.
Oh, I thought you just used Firefox. Yeah, I use a different, like internet.
Well, because Brainerd's on, Dr. B is on Google Chrome.
Yeah, if we use Internet Explorer, we're safe. What?
Well, like, we've been having issues calling the professors, but it's just their last name. Me specifically, but it's like from endearment, like Dr. Buckman is from my name.
It's like Harry Potter. No.
I mean, the Google does have the houses and everything.
I like first.
It's not big.
Hit
I
present.
promise it's
Present
not big.
top right.
Right, okay.
Normal house.
Where's the- Okay, hello classmates. We are Julia, Caleb, and Austin, and we have the first question, which is explain which controllers of renin release caused the increased renin release seen in our patient's left kidney. So to start off, and since we're group 1, I wanted to go into a little bit of the physical exam findings that are relevant to this mechanism. And that would be the abdominal exam of our patient. It was pretty much normal, soft, non-tender, except she had that scar from getting her tubes tied, which she opted to do because her physician did not like the birth control mixed with the uncontrolled chronic hypertension for the exact reason Dr. Anderson was just talking about, which is about that turbulent flow, that clotting risk is really increased. So she opted to get that tubal ligation, and then the other one was from an appendectomy. And so that's her surgical abdominal history. And then for what's heard on exam, this is what's important, what's here in red, and it's the bilateral abdominal bruits are present lateral to the umbilicus with a diastolic component to the left root. So we put up the little exam findings here, periumbilical region, and then the findings, you can hear it as it goes down to the left. And then this is a classic presentation of renal artery stenosis, just being able, especially that diastolic component with that heart sound, or I guess vascular sound.
So here we've got an overview of the RAS system, the renin-angiotensin system. If we start with a decrease in blood pressure in the glomeruli of the kidney, sorry, I can't reach here, but the top left there. We see the direct effect being a decreased afferent arterial blood pressure. So that causes a decrease in local blood pressure and an increase in renin release in the JG cells. That, coupling with constitutive angiotensinogen release from the liver, causes angiotensin 1 to be circulating throughout the body. And when that comes into contact with ACE, or angiotensin converting enzyme, situated in the lungs, it converts into angiotensin 2. Now here's where we start really seeing the effects, because
Is ACE only present in the lungs?
It's
mostly in the lungs. There are trace amounts elsewhere in the body. But
I think trace is too weak of a word. There's significant amounts of converting enzyme in other places. The most is in the lungs.
okay.
There's significant conversion before it's in the lungs.
So, but after exiting lungs, it's converted into angiotensin 2, and this kind of has a two-pronged effect. On the one hand, there's interfacing with the adrenal gland, specifically the zona glomerulosa, and that causes release of aldosterone. But also, there's a direct vasoconstriction acting on the efferent arteriole of the glomeruli. So going on this aldosterone reaction, it affects the collecting ducts and causes reabsorption of sodium, secretion of potassium, and to this gradient, reabsorption of water as well. This increases blood volume, and coupled with vasoconstriction, causes increased blood pressure. So if we could hit next, and kind of some key points. So We'll get more into specifics on the next slide, but the basics are it's activated in response to low blood pressure or hyponatremia. Hyponatremia. And it affects the adrenal gland by upregulating aldosterone release, which saves sodium and acts to excrete potassium. So the effect in the kidney is vasoconstriction, specifically of the efferent arteriole.
All right. So now we're going to walk through a few mechanisms. So one of the main mechanisms that we went over was the increased solute delivery to the macula densa cells, which would cause an increase, or sorry, a decrease in the renin secretion from the JG cells. Second, we have stretch of the afferent arterioles. Increased stretch would cause decreased calcium, or would cause calcium efflux in the JG cells, and would therefore cause decreased renin release as well. It's a second mechanism. Third, we're going to see, as a result of vasoconstriction and activity of mechanoreceptors, we're going to get increased release of prostaglandins, which is going to cause vasodilation to kind of counteract that vasoconstriction. The only mechanisms by which we see, so that was actually a mechanism of increased renin secretion, but let's see. That's the only main mechanism that we had to actually talk about increased renin secretion. Otherwise, it's just generalized sympathetic activity increase. So this is a chart that kind of walks through the relevant factors throughout the whole process. Just some basics to go over. Increased renin is going to cause an increase in the presence of angiotensin II, which would activate and inhibit the negative feedback mechanism. Let's talk through some of the other things. COX-2 would increase causing release of vasodilators, namely EP and IP2 prostaglandins, which would cause increased cyclic AMP activity and therefore renin secretion.
I also want to make a point that when I gave a presentation like this, similar to Dr. Joshua, and I said that it's decreased NA plus that's coming through and sensed by the JG cells, he corrected me and said that it might be the chloride. So I don't know which, but it's either, it might be one or the other.
Where's the evidence for that? Does anybody know?
I think they don't have. Never mind. I was thinking of nitric oxide, where they haven't determined exactly when that was secreted. You were talking about.
They also have not determined yet the mechanism that takes pro-renin over to renin. So that can be due to the fact that we don't know if it's NA or CO yet.
Yeah, there's good evidence that it's chloride. It actually comes from a researcher at the University of Kentucky.
Who?
That's why we have a hard time believing it. But it's pretty convincing.
What was the last name?
I don't think he's there anymore. He used to be.
All right, so we've got a quick activity for you. I know we're kind of short on time today, but take 2 to 3 minutes, read over the prompt, or I can read it out for you guys if you want. But pair up with friends, colleagues, and use the internet, any notes, anything you'd like, but come up with a creative solution. This dilemma.
What is nephrotic syndrome?
So nephrotic syndrome has several different downstream effects, but it's broadly grouped as kind of a group of symptoms. The main ones, especially pertinent to this dilemma, are proteinuria and low serum albumin levels. There can be other effects like inflammation or local swelling, but these are the pertinent symptoms.
Is it only of the glomerulus? Cyclosporin?
That's
Is it only the glomerulus, afferent of the glomerulus, no other arterial?
Correct. That would be the key. Yes.
I mean, it's got other uses, but for the renal system, this is it's also an immune suppressor.
I think you should give it because it would decrease the GFR.
All right, Samir's got the answer, everybody. Samir has the answer.
I think you should give it because it'll decrease GFR and decrease maybe capillary hydrostatic pressure, decrease the amount of proteins leaving.
Yes, that sounds good. So it'll decrease GFR, and that will solve the problem, or at least alleviate somewhat the problem of proteinuria and low serum albumin levels as a result. But as we saw in our mechanism, reducing the afferent arterial blood flow would increase production of renin and serve to systemically increase blood pressure.
So you could give an ACE inhibitor or something of that sort in conjunction with it in order to stop the renin action.
Right. So you've got a list of antihypertensive drugs that you could choose from to counteract this effect. So you do want lowered afferent arterial pressure, but you don't want systemic hypertension because that could kind of counteract that effect down the line and cause increased pressure in other nephron areas. So that's a good answer. So dose with that drug and also include an antihypertensive agent.
Which one?
There's a variety to choose from. You could do ACE inhibitor because that'll counteract the renin.
Anything else?
Diuretics. Would you do that over?
Well, I did both of those.
Both. Okay. So there you go.
I also want to note that I was at Churchill Downs yesterday and I noticed it says star Lasix at the bottom. And so then I asked my aunt who's a veterinarian and every single horse has the L. And it's because in Kentucky we can use Lasix on the horses to diurese them so they weigh less, but it's against the law in New York. So we need to work on our, we need to get, it doesn't look great for us in this equine state. But anyway, any questions?
Dr. Beckel, tell you what LASIK stands for?
Oh, did he, it takes 6 hours. It take 6 hours for it to move through?
No, it takes 6 hours. It lasts, its function lasts for 6 hours.
6 hours.
That's how they named it. Lasts 6 hours. LASIK.
Oh. Wow, nice. It's about the creativity I would expect for something like that.
All right. So that was it. Hope you enjoyed.
There's always so much actually.
Are you? I couldn't. I know. I don't know. That's what I said. What? I did. They should go. How late?
I know.
How are you going? Oh, okay. Are you couldn't fly?
Do you like them that much?
Okay, so 9 hours is left, or 7 hours.
You have to log to it out. It looks like.
Wow. He should check the email.
I know.
Watch mine. Mine's like, I don't even know how much.
Mine has 0. All of mine are completely organized.
You have too much time on your hands.
No, it's just if you stay on top of it, it's not hard.
Mine was already too far gone, like, whenever I got get it home, I guess, I don't know. As to be in a little direction, really tomorrow.
To get a direct flight
So I
back
think
to
you
and
were
from
going
Toronto from Cincinnati. What the hell?
That's unfortunate. Think about your state.
Remember to skip
But I already know the answer. I just asking questions over and over.
I was gonna ask.
I flew to and from Washington, D.C.
I didn't push this.
I mean,
Yeah,
That was-
$60.
it wasn't.
Like the data, but it was like connecting into the
Right.
So I
I'm
just
just gonna
like
make sure.
Took the flight.
Just put this up before everybody comes in. This, yeah, we would take a
It would be a
long
good
time.
idea.
Everybody would do that, yeah.
didn't say anything or anything.
I know that.
I just found tickets that were really, really cheap that connected to the airport.
I can do two weeks.
Stop looking at it. Alrighty, guys.
You and your notes.
Learn about some random determination. Zach, stop it.
All right, so our question was, explain the renal vein renin determination in this case. And then group 1 did a really good job of explaining how renin is secreted, so I'll just be repeating. So the first one is baroreceptor mechanism, where your these receptors on the afferent arteriole are sensing pressure. So if you have a decrease in pressure, it's going to release renin And then the second one is the sympathetic nervous system, where your sympathetic nerve fiber is releasing renin. And then the macula densa, which is your the chemoreceptors on the distal convoluted tubules, are sensing decrease in pressure. So it's going to tell the JG cells to increase the secretion of renin. Okay, so to go over just basically how they determine the renal vein renin, it's called a renal vein renin assay, and they collect the renin samples via a catheter in the femoral vein, which is like down through your leg right here. It's like in this area, and they access the inferior vena cava in both renal veins that way. The normal values are about 0.4 to 4.5 on a regular diet with no salt restrictions. And as you can see, our patient, the inferior vena cava and the right renal were both within normal range, but both on the higher side of normal, and then the left renal is way above normal. And that is due to the decreased renin from the left renal, from their last kidney. And they use this test to predict like what kind of surgical approach they're going to take, whether it be removal of the kidney or just the redirection of one of the blood vessels. And in our patient's case, it said in the case study that they placed her on ismelin, which is an antihypertensive, for 4 weeks before they did this measurement. And that is to kind of combat that central nervous system stimulation of renin, so that all you're seeing is that kidney renin. That way, when you're getting these values, you're majority just getting the kidney renin values.
You said that they use this to determine whether they're going to do what procedure they might approach. What kind of values would be looking for procedures that aren't?
Like they were saying,
like
like if you can determine that it's a bilateral, then you're going to take one approach. Where if it's more of a unilateral, then you're going to take another approach, and so forth and so on.
So why is the inferior vena cava renin?
We're going to get there. We're getting to that. We're good. All right, so this is our question. Bring here and share. So these are our patient values up here. So like, why do you think in case anybody didn't know, both the left and right renal veins empty into the inferior vena cava. And so why do you think that inferior vena cava renin is low, even though our left renal vein renin is so high? So you guys can use do not answer. Don't answer. Tyler, you don't answer.
I didn't tell him.
Okay.
My question, you know the
Oh, it's like we were just trying to show like this, but this
I'm
is
just saying,
like
what is that?
this is some kind of they use this if you have clot.
It was just a picture that I was trying to find.
I will show
where the inferior vena
What?
cava was.
So then it is like inferior to the renal vein stuff, right?
It runs from below the
Well,
and
that's-
all the way up past them.
Oh,
It can be above and below. Like there's inferior vena cava above them and below them. Just think hair and then hair. Yeah.
Exactly.
You can use your laptop to research if you want. If you don't know the answer. Or just say, I don't see anyone pairing. Huh?
I'm not to tell you.
Good. All right, then you can share.
What are your thoughts?
No wrong answers. Safe space. Yeah.
Where's the source of
the right vein.
Okay, does anyone think they have inferior? Anyone? I think they're still thinking. Okay.
So it only comes from the left, right? If you have low perfusion, what's happening? What flows along with what
It shows a level 4.
itself?
All right, we hear some quieting down. I'm gonna pick on someone first. Alexis, would you like?
No, wait, don't pick on Alexis. Because she knows the answer. Wait, don't pick on her. Pick on somebody else.
I'm still thinking hearing
Yeah. All right, Abby, go. What do you think?
Well, I'm still trying to figure it out.
Okay, same.
But I guess, well, go, I mean,
Go ahead.
I'm thinking, I'm sorry, I really don't know.
Can we pick on one of you
Is
guys to give us a good
Is it correct
explanation?
to say that you can measure
Sure.
from the superior
Okay.
vena cava?
No, but if you can.
Right, just go to the next slide, because we don't know either. Like, we had a bunch of theories and we asked Dr. Brainerd and he really didn't seem to give us a real good explanation either. So do you want to just go to the next slide? Okay, so like you were proposing, I found this in one study where they took so these are both the kidneys and this is representing both renal veins. And you have your inferior vena cava above the kidneys and your inferior vena cava below the kidneys. So like one of my theories was, where was the sample? Like, is it because the sample was taken from a portion of the blood that hadn't been like circulated through with the left kidney yet? Or, and then we were thinking maybe it's because it's a combo of the two veins. And this was on our slide as well, where you take it said to subtract the vena cava value from both the right and left. So if you subtract the vena cava, which is 4 from the right, which was also 4, you get 0 renin from the right kidney. And from the left, 15 minus 4, 11 renin from the left kidney. But it's not really like an average. So we're still also not real sure on that one. And then Katie had.
Yeah, so for the rate of renin from the left, if we think about, I had talked with Tyler, and if you think about it, the stenotic kidney, you're going to see a reduced GFR. So we have such a low rate of the blood flow. It's maybe not contributing fast enough, even though there is such a large amount of renin activity. You might, Tyler did a really great analogy of you're dropping drops of food coloring into a flowing river. It's going to dissipate. It's not going to make such a big deal on that communal vessel.
It'll contribute so slowly.
So slowly it's not going to.
And then when you're taking a sample of the left or the right renin, it's potent, but when it's mixed with the other bloods, it's diluted. So that was another theory that we had. So and it's bound to other proteins or enzymes or whatever.
Well, I'll ask you 2 questions that will lead you to the answer. The first is, what fraction of the cardiac output goes through the kidneys?
About 20% to 25%.
25%. So where's the other 75% of the blood? Does that blood come back to the inferior vena cava?
Not all of it. Some of it's superior. some of it's superior.
Okay. But so there's the inferior vena cava gets venous drainage from the other 75% of the body that has nothing to do with the kidneys. Okay. Number 1. You'd expect whatever the kidneys are doing is going to be diluted by the vena cava blood returning from other areas. Question 2 is, what's the relative blood flow of the 2 kidneys? We have that data in another. Split function renal test. Who's doing
I think it's a later group. I think it's funded my company.
that? So what's the relative blood flow of the left versus right kidney?
Slow. Yeah, one is slow and the other.
See, this left renal vein is 15 nanograms per mil.
Yeah.
So you're collecting a mil of blood. You collect a mil of blood from the right kidney. They're equal volumes. But
One is
the
constant.
volume that's actually coming from the right and the left is quite different. So if you were to multiply concentration times volume, you find out that the left isn't working at 15, so to speak.
Right.
Okay, so it's got 15 in a mil, but it's only producing 3 mils. So the right kidney's got 4 in a mil, and it's producing 10 mils. So it's systemic volume diluting the renin, and the low blood flow on the left side is really not producing a whole lot of. It's not producing renin at that. You look at that 15, you think it's really high, but when you multiply it times the actual volume, with kidney actually has. It lessens the impact in your mind. It's just mass flow. It's kind of
What was that?
answer to your question.
In this patient's case, the left kidney was about 30% of the blood flow of the right kidney.
What is it?
About
30%. The left patient was about 30% as much blood flowing as compared to the right kidney.
So it's one third of the right kidney. So you can divide that 15 by that, and it brings it down to something less than that. If the impression you have in your mind when you first see the number, you don't think about the rate of flow in addition to that. Rate of flow is an important consideration. I'll bring it up again later when we get to the quick function test.
That's all we have.
I'm only talking essentially some of that right. When I was talking about this, you find right dilution, like just like you do. And I hear that river, it's like that. Kidney can't flow. You don't have a flow rate in that damaged kidney. So while the concentration is huge, you don't have it leaving. It's not getting into the system. It's not flowing. And like, that's where my mind went, but I was like, what? How's that work? Exactly. To be fair, I wear these. So it wasn't that far. It's significant.
I didn't see your eyes kind of just go towards the smiling face and you're so
I'm dead. I'm sorry.
Oh, yeah. Your eyes just kind of go to
I just prefer a little.
Have you ever?
You're not used to using it.
I got it. Okay.
All right. So we did our presentation. We're going to explain how increased sodium reabsorption causes increased MAP. And relating back to our case study, we know that our patient is suffering from hypertension due to left renal artery stenosis, but I want to explain a little bit as to why they're suffering from hypertension. So what's happening is having stenosis in the left renal artery would cause ischemic blood flow to the diseased kidney. And because you're having a decrease in renal blood flow to that kidney, you're ultimately going to have a decrease in glomerular filtration rate, therefore a decrease in sodium and chloride delivery to the macular dentate cells. So the afferent arteriole will sense a decrease in stretch, and that will ultimately sense the JG cells to increase their secretion of renin in order to signal that the RAS cascade to occur to ultimately increase sodium reabsorption and to increase blood volume and blood pressure. And you can see here, as the previous group mentioned, how the left renal vein activity that is sensed with an assay would be higher compared to the right renal vein renin activity. And yes.
What is the FS?
So sorry about that. We will talk about later about Frank Starling. Frank Starling. Yeah.
So just a little bit more about the renin, angiotensin, aldosterone system. This is the decreased renin, or the increased renin is going to increase angiotensin 2, which is going to work to increase aldosterone, increase sodium saving, which is going to increase blood volume, and eventually that's going to cause the increase in blood pressure that we see. That's pretty much all there is on that.
Yeah, because of that increase in aldosterone, what that's going to do is that's going to signal to the distal convoluted tubule and the collecting duct to increase that sodium reabsorption. And because it's sodium, water of course will fall, and overall will increase that.
Okay, so now we get to the fun part. So the Frank-Starling effect, as Kayla was talking about, how increased renin release will eventually lead to an increase in your blood volume. And when you have an increase in your blood volume, as you can tell from this diagram, you're going to have more blood filling the veins, so your central venous pressure is actually increasing. So what's happening is there's more filling of the heart, and so that is going to increase your preload. And that increase in preload is actually going to allow the heart to stretch more and to a more optimum overlap of the actin-myosin. And
It's not allowed.
it will cost. Okay. And so your stroke volume will be increased, and an increase in stroke volume leads to an increase in your arterial blood pressure. And that just ties it full circle.
So here we have a quick matching activity. So I'll give you a minute to discuss what are the answers, and then all right.
Yeah. Let's see. One second. Number one, let's do Macy. Yes, good job.
You ever heard of angiotensin 3?
Yes. I never heard of it. Like, I never.
I didn't know it existed.
It's part of the breakdown, isn't it? Yeah.
Okay.
Some people refer to angiotensin 3 as being the stimulator, because when the angiotensin 2 binds to the receptor is internalized and another amino acid is cleaved off, and they refer to that as angiotensin 3, and some people say that's the active hormone that's causing the aldosterone synthesis inside the cell. It's kind of a matter of semantics. In case you hear it, angiotensin 3 is sort of internally produced within the cells that are making the aldosterone, and the stimulation of the synthesis and release process.
And it's a cleavage of 2 that generates 3.
Pardon me?
It's a cleavage of 2 that generates 3.
Right. So that happens internally in the cell. So once angiotensin 2 binds to the receptor complex is internalized, and then there's another amino acid cleaved up. Some people kind of try to refer to that as angiotensin 3 acting within the cell to produce the aldosterone stimulation.
All right, so number two, Samir. Not that one.
I'd say fast,
It is actually
slow.
it is slow. And if you think back to, I believe it was Dr. Schirmel, in terms of response systems, he mentions how the renal system, it takes at least a couple of days in order for compensation to occur.
What's the slowest part of it?
I believe the slowest part of it is using the correct, trying to figure out for the renal tubule to use the correct channels in order to either excrete more acid or bicarbonate, depending on what the problem is.
Well, from the viewpoint of when it's released in the blood or cleaved in the blood, the hormone makes its way to the receptors pretty fast, but then it has to go internalize the receptor, cause synthesis of aldosterone, and then aldosterone has to travel through the blood and go to a receptor on the kidney, internalize that, and cause synthesis of sodium potassium transport proteins and so forth. So it's the synthesis process and all that goes on with the
Receptor.
reticulum, the smooth reticulum in the cell, the Golgi complex, all that process is relatively slow compared to the bloodborne delivery of the hormone. The cleavage process of angiotensin is fast. It's the synthesis process in itself to make the aldosterone and make the transport proteins in the kidney. Those things take longer.
Do you,
Messenger RNA has to be mobilized and all that kind of stuff.
so I know with acid base, the kidney is the slowest response system of what we have. But in terms of blood volume, since the kidney is solely responsible for our blood volume in regards to regulating
Along
it,
with thirst.
along with thirst, what do we, what speed are we talking when we talk about that? So if I cut someone off from having liquids, or if I cut, or what speed are we gonna start seeing renin release? Is it within a day? Is it within
No,
3 days? Like
Well, what's the main stimulation of renin release is what? Sympathetic nervous system.
Okay.
Sympathetic nervous system is fast.
Okay.
Blood pressure drops. So it's the rate of stimulation of renin can be pretty quick. But then the transduction of the aldosterone signal and all that, internal synthesis, building proteins and transporters, transporting them to the surface of the cell, sticking them in the membrane. Those are the processes that take place.
And that's what, 2 days?
Yeah, something like that. Yeah. And then the building up of the volume, saving the sodium, saving the water.
Okay.
If you don't drink any water, you're not going to rebuild it in volume. If you have that thirst, and are you going to be able to press an activity within the kidney also?
And then
And the last question goes to Katie.
I didn't know it increased the preload.
Does preload increase afterload?
It can.
When can't it?
because I think the afterload has to do with cardiac output. So I guess if you're increasing the stroke volume, it would later increase it.
So what is afterload?
Is it the aortic pressure?
That's the main component of it, or the diastolic aortic pressure. But
Mhm.
just what is it? If you were to define an afterload, how would you define it?
It's probably wrong, but is it the amount of volume that's left after?
That's one description of it, the volume that's in the ventricles. What is
What
it?
it has to work.
Resistance of the body or of the exiting blood from the left ventricle. Resistance against the blood or leaving the ventricle.
It's synonymous with SCR.
It's all
Well, that's a high
the, all the forces
Something like that.
that the ventricle has to overcome in order to move blood into the aorta. So if it's the wall of the vessel, if the wall of the heart is stiff, it has to overcome the stiffness. If the diastolic pressure is high, it's got to overcome that. If the volume in the ventricle, the preload is large, so it has to lift that. So preload is always an increase in afterload by weight. So wall stiffness, preload, diastolic blood pressure, peripheral resistance. Once you get the blood moving, you have to keep it moving, so you have to go through the peripheral resistance. Those are all afterload issues. After you start ejecting blood, what forces do you have to overcome to eject blood from the vein?
That is all we have. Are there any questions?
There was something I wanted to ask.
Yeah.
Can you go back a couple of slides real quick, because there was something.
Back again?
Back one. Oh. So we said that stretch, lack of stretch releases renin, lack of afferent arterial stretch. We said low sodium chloride delivery to the macular denser, probably chloride more important than sodium. And prostaglandin release. Why are the prostaglandins released?
My understanding, prostaglandins are released in order to help. They help dilate.
It's low blood flow and low blood.
Why? Why does low blood flow release prostaglandins?
Because it senses that because there's going to be a decrease in filtration rate, so prostaglandins are released in order to try to dilate the afferent arteriole.
That's the reason that they're released, but what is the mechanism that causes their release?
Is the next group talking about that or?
Is it the use of the sympathetic nervous system being involved, or I'm not sure.
It's the oxygen concentration in the interstitial space of the left kidney.
Well,
Hypoxia.
It's-
Hypoxia is one of the reasons that
Yeah.
prostaglandins are released.
Yeah.
damage causes prostaglandin release.
The left kidney is ischemic and hypoxic.
Pretty much.
Just turn it up.
No.
Turn it down.
You burn it up?
I always know it's hot if I'm hot, because I'm like always cold.
Because Artie ghosts us all have every day.
Oh, yeah, Artie always like turns it up to sauna temperature.
Well, normally I'm freezing. I'm probably in the freeze, but.
I know it's hot,
What's your topic?
Oh, yeah.
What are you?
Oh, yeah.
How I feel.
Okay, so again, back to the angiotensin 2 actions. Oh, Alexis is speaking, sorry.
All right, so we've seen this like 4 times now. So yeah, angiotensin 2 would be released in the juxtaglomerular autoregulation mechanism when blood pressure drops, when GFR drops, JG cells are released, renin into the bloodstream, and renin will lead to the formation of angiotensin 2, which will then act on several different organs to increase blood volume and increase blood pressure. It's going to release aldosterone from the adrenal gland. It's going to directly act on the proximal convoluted tubule in the nephron to increase sodium reabsorption. Aldosterone will increase sodium reabsorption in the late distal tubule and collecting ducts, and this is all going to function to increase water reabsorption and increase blood volume. Angiotensin 2 also causes the secretion of antidiuretic hormone from the posterior pituitary, and this is going to act on the collecting ducts to insert those aquaporin channels into the apical membranes and facilitate more water reabsorption. It's also going to facilitate more urea reabsorption in the medullary nephron, which is again going to increase the osmotic potential of the peritubular capillaries and function to increase water reabsorption again. So yeah, overall, angiotensin 2, the main goal is to increase blood volume and increase blood pressure, and it's going to cause secretion of aldosterone, catecholamines, which will directly act on alpha-1 receptors on
blood vessels to vasoconstrict them, increase systemic vascular resistance, increase afterload, increase preload by increasing blood volume, then release antidiuretic hormone as well. So it does a lot of things.
So again, just as a general overview, we just wanted to hit the key points of angiotensin 2 and its actions that it's a part in. So again, it's released when blood volume is low or when blood pressure is low, and it acts or participates in the actions to stimulate aldosterone release by the adrenal gland. It's also considered a systemic vasoconstrictor. It helps to enhance the sympathetic nervous system release of norepinephrine and epinephrine. It also stimulates the release of antidiuretic hormone from the posterior pituitary. Again, as Dr. Anderson had discussed, it also helps to simulate thirst and expands the ECV and increases blood pressure.
They have a role in the proximal fluid.
Yeah, directly increases sodium absorption.
How does it do that?
I'm not sure the mechanism. I know it's a direct effect.
What was the question? Does angiotensin have an action in the proximal fluid?
Yeah. On sodium reabsorption.
That's what it said.
Is it the same mechanism as the aldosterone mechanism?
As
No.
The aldosterone mechanism in the distal figure?
Yeah.
What is it do?
Is the efferent arterial also
Doesn't it help promote the activity of those channels like the sodium bicarbonate channels in the proximal?
Actually, the way you're saying it's not inserting more sodium potassium transport.
It's just upregulating their
That's upregulating co-diffusion aspects. It also increases hydrogen. Carbonic anhydrous activity.
which would also
It improves proximal tubular reabsorption. Proximal tubular is pretty good at reabsorbing sodium without any help. What else helps proximal tubular reabsorption of sodium? What other hormone besides angiotensin 2 is considered a hormone?
That thyroid hormone?
That increases phosphate sodium transport. That's in the proximal tubular as well.
Yeah.
Very nice. But the right hormone also works with lipid and calcium.
Right. All right, so we have a little question. There's 5 correct answers here. I'm just going to call on random people for each number and tell me yes or no. And then if you know why, tell me why. So would angiotensin 2 directly or indirectly increase the activity of the sodium potassium chloride pump in the thick ascending limb where Lasix works with Bobby?
Is the yes. What's my name?
Bobby? Yeah, right.
Is it direct or indirect?
I'd say it's, I think it's indirect because of aldosterone. And aldosterone's mainly late.
Does aldosterone stimulate that pump?
is it a thickens
I'm gonna say indirect. I'm gonna say indirect.
location?
Is it, are we talking about angiotensin 2 or aldosterone?
Angiotensin 2. Did you answer? Sorry.
Aldosterone increases the number of sodium potassium exchange pumps.
In this.
Sodium potassium exchange pump?
No, but I thought it helps. I thought I know it was like it helps with the activity insertion of the sodium potassium pumps in the distal convoluted tubular ventricle. But I also thought aldosterone did have an effect on promoting that increased activity of the NK system.
What else does?
Of this pump. Well, angiotensin 2 indirectly would by promoting the increase in aldosterone secretion.
Does the vasopressin have any action?
Collecting that. Yeah, collecting that.
Yeah, by the antidiuretic.
Yeah, vasopressin.
Does the diuretic hormones have any stimulation of that NKCC?
Probably.
Yes, it does. So that this inserts water channels, but it also increases the activity of that pump.
Okay. All right, number 2, directly decrease sodium reabsorption in the proximal convoluted tubule.
Angiotensin.
Brittany,
I mean, it wouldn't decrease it.
right, so it's wrong, it said increasing, you're right. And it's a direct effect, as we talked about earlier, decreases the activity of all those channels in the proximal convoluted tubule. All right, number 3, indirectly increase urea reabsorption in the collecting duct, an indirect effect of angiotensin 2. Is that correct? Alex?
Did you already answer the question in the question?
I don't think so.
True or false? Is it true or false?
True.
Right. Do you know which hormone it was stimulated to do that?
ADH.
Right.
But you answered it in the question.
This is indirect. Yeah, but
I know, it was supposed to be true or false.
Alex is having a hard time.
And you have to pick 5. You have to pick 5 that are right.
Yeah.
All right. 4, increase androgen secretion from the adrenal medulla. Does angiotensin do that indirectly or directly? Iman.
It is, I'm going to say it's.
Like testosterone, estrogen, like angiotensin, stimulate release of that.
At all, so it's direct or indirect?
Right.
I guess it only.
Yeah, it's all.
Yeah,
I,
it's false.
Yeah.
It's aldosterone.
Would its sympathetic effects not have an effect there? Because if you push your blood pressure up,
I'm sure
your sympathetic.
I'm sure there's a situation where it might do that, but generally speaking, I don't think it's supposed to. All right, number
It's not
5.
intentional, but it does some because of the side chain cleavage precursors. And those zones are not isolated from each other, and you get precursors that will leak into other zones. Cause some reduction of androgen. And so it's, there is some.
Okay.
So then that was, there was no answer to that.
I was just going off our
That's
notes.
not,
It
that's
wasn't
not the
mentioned.
point of what it's trying to do. But it does actually happen because of mass leakage of precursor into the other area where there's enzymes that can carry it forward to produce androgen. And or aldosterone, and or catecholamine.
All right, 6, would angiotensin decrease venous arterial pressure?
Tyler.
No, it would increase it.
Right.
What was 5? Was it true or false?
Oh,
We didn't talk
sorry.
about
Yeah, sorry.
Is it false?
So 5, what do you think, Artie?
True.
It's true.
That's true.
Because it increases
It
catecholamine.
increases the activity or release, but it doesn't stimulate.
Isn't that the receptor on blood vessels which causes vasoconstriction? Alpha 1 adrenergic receptors.
It enhances the release of norepinephrine, but it doesn't directly stimulate.
Right, but indirectly.
Well, it doesn't stimulate them. It enhances the amount of release when they're stimulated.
The amount of release.
Semantics there.
Yeah. Tough
Wait a
question.
minute, say that again?
angiotensin enhances sympathetic release, but it doesn't stimulate the receptor to do it.
So when we talk about the fact that angiotensin 2 causes a systemic arteriolar constriction in our blood vessels, it's not that we are stimulating them more often, it's that we are causing a higher rate of release when they are stimulated.
And angiotensin has its own receptors, so angiotensin receptors stimulate action too. But it's not through an alpha-1 receptor.
But it's not called out. Okay, gotcha. I thought they,
Angiotensin receptor.
I was getting at the indirect effects by stimulating release of norepinephrine.
Well, like you said, it's a receptor activation. It
Right.
doesn't activate the receptor, it enhances the release once it's been activated.
He's saying that there's no effect
So
on
he
its
said
actual
alpha
electrical
one
impulse. There's no
enhances
activation
release
of it.
norepinephrine, that would be correct.
It just they allow more
See the
to.
difference between activating a
released.
receptor and how much it releases? So what it does is it increases the packages and storing of norepinephrine so that when it's released, more is released.
Oh,
But it doesn't activate the receptor to release it. It has to be activated by some alpha agonist,
Right.
not by angiotensin 2.
Okay. All right. Then 7 and 8, or let's do 7 first. Would angiotensin 2 increase blood volume? Austin.
Are you asking directly or indirectly?
Yes.
I would say one pathway is indirectly through aldosterone.
No, just yes. Not yet. Would it do it? Would angiotensin increase blood volume either directly or indirectly?
Yeah.
Right. All right.
Is it true and false?
now it is.
8, decrease preload and afterload. Angiotensin 2 decrease preload or afterload.
Immaculate it's for the class.
I like your questions. I thought about
So just relating it back to our case study, we saw again that our patient had chronic hypertension that was not being controlled on several medications. She was currently taking a vasodilator, a diuretic hormone, a diuretic thiazide, and also an alpha-2 agonist. And those combination of drugs were not helping to reduce her blood pressure. So we thought if the patient was compliant to take another medication, she had not been introduced to ACE inhibitors. So we just thought an ACE inhibitor would just help to reduce her arterial pressure by decreasing her preload and her afterload, downregulating her sympathetic nervous system activity and releasing norepinephrine. All of this to increase her renal excretion of sodium and water, and then ultimately to decrease her blood volume and blood arterial pressure.
what's her sympathetic nervous system activity like?
It was high, or I'm sorry, it was normal. They did a VMA test later to show that her catecholamine excretion was low or normal. I'm sorry.
Where do those catecholamines come from?
The adrenal medulla.
So where do most of the catecholamines in your blood come from?
The adrenal medulla.
If most of the catecholamines in your blood don't come from the adrenal medulla, where are they coming from?
Is it?
I don't know.
Spill over out of sympathetic nerve terminal. Majority of norepinephrine in your blood comes from leakage from sympathetic nerve terminals. You have a lot of them all over all the blood vessels, all kinds of places.
So that would speed up its diffusion throughout the body and you're in a fight
If you take your adrenal glands away, norepinephrine doesn't go down. Epinephrine does.
But
So do aldosterone,
But doesn't epinephrine come from norepinephrine?
cortisol, and androgens,
well,
but not norepinephrine. Norepinephrine, most of the circulating norepinephrine is derived from spillover from sympathetic nerve terminals throughout the body.
Is epinephrine decreased because the only place in our body that we have a significant amount of converters from norepinephrine to epinephrine is in the adrenal medulla? Okay.
So the sympathetic activity of this particular patient is what? You say you want to downregulate sympathetic activity, but what is their sympathetic? Does it need to be downregulated?
No, but that was just one of the actions of it.
That's something you can do. But hers is, she's got hypertension. Her baroreceptors are being overstretched. She probably has low sympathetic activity.
So an ACE inhibitor would not be a good
ACE inhibitor would be particularly good for her, or an angiotensin II receptor blocker, or alleviate the stenosis. Would be the most direct and most important thing to do.
But she didn't have surgery.
Mr. Tolliver has an aldosterone secreting tumor. You could do all kinds of things to block aldosterone and angiotensin and sympathetic system, but just take out the tumor, get rid of the aldosterone.
All right, so another class of medicines where you can interfere with the RAS system is ARBs, angiotensin receptor blockers, and this class of medicines, they'll end with artin, like losartan, olmesartan, and their mechanism is to stop angiotensin II from binding to type 1 angiotensin receptors. So like ACE inhibitors would interfere with the angiotensin converting enzyme, whereas angiotensin receptor blockers don't mess with the enzyme, they just block the binding to the receptor itself. So the side effect that we didn't mention about ACE inhibitors was that you can have a severe life-threatening reaction on an ACE inhibitor because of ACE. The ACE enzyme normally degrades bradykinin. So if you inhibit the ACE enzyme, you're going to allow for the buildup of bradykinin, and that could lead to angioedema, which is like swelling, like dermal swelling, and it can cause bronchoconstriction as well. So you can have shortness of breath, throat swelling, facial swelling. But ARBs, they don't interfere with ACE, so there isn't that buildup of bradykinin. And the side effects of, or something you have to watch for with both ARBs and ACE inhibitors are hyperkalemia and metabolic acidosis. Because if you inhibit angiotensin II, the entire system, you're going to inhibit aldosterone, aldosterone normally brings in sodium and excretes potassium. So if you inhibit that, there's going to be more potassium in the plasma compared to normal. So you may lower blood pressure, but you might have hyperkalemia. And you can see that on EKG with the elevated T rate. All right, so just a bunch of top-level questions here. What is the risk of combining a diuretic with an ACE inhibitor or an ARB? So our patient, she's on a thiazide, which is a potassium wasting diuretic. No, a potassium sparing diuretic, because thiazide would act on the early distal convoluted tubule to inhibit those sodium and chloride cotransporters. It wouldn't mess with potassium at all. So if you were to put a patient on a ACE inhibitor with a thiazide, what's the risk of that?
Start over again. Are Lasix and thiazide potassium wasting or potassium sparing?
Well, Lasix is potassium
sparing.
wasting. That's the Lasix potassium wasting for sure. Thiazide, it wasn't labeled as potassium wasting, but it only inhibits the sodium and chloride cotransporter. So
what makes Lasix potassium wasting? Potassium wasting meaning potassium ends up in the urine.
Right.
And you could become potassium depleted in the blood.
Right.
What makes Lasix potassium wasting?
It inhibits that NKC pump in the biggest anyway, so less potassium to be absorbed and more excreted. No. This.
potassium reabsorption is relatively passive in the early part of the network.
Like in the proximal longitudinal and
Well, yeah, particularly there, but also in the loop.
right.
It doesn't depend on transport. So how does potassium get wasted?
Doesn't get reabsorbed.
Because it gets secreted
Right.
in the distal tubular collecting.
Right.
So why does Lasix cause potassium secretion in the distal tubular collecting?
I don't know the answer to
If you don't reabsorb sodium out of the loop, where do you reabsorb? Yeah, and that mechanism is directly tied to potassium secretion.
So if we can't.
Not saving sodium early means you have a lot of sodium to save later. And that mechanism is aldosterone-driven forced potassium secretion. So the reason you lose potassium is you don't reabsorb sodium in the loop is because you reabsorb a lot more sodium later. That forces potassium secretion. So wasting diuretics are diuretics that stop sodium reabsorption fairly early in the loop or early in the or in the distal tube. Thiazide does that too. Thiazide's just Lasix is here and thiazide's here in terms of where they work.
Right.
So thiazide works early distal tubule, late loop. Lasix works early loop, early distal tubule.
They're both
So they
wasting.
both deliver too much sodium to the majority of the distal tubule and the collecting tubule. That will increase presence of sodium there and increase the amount of sodium reabsorption out of the distal tubule and the collecting tubule, which will force potassium secretion. And that's why potassium gets lost.
Well, the way we would
So
thought,
what spares potassium is not to reabsorb sodium late in the network. An aldosterone inhibitor, for example, is potassium sparing diuretic.
like spironolactone.
Yeah, that's what spironolactone is, aldosterone antagonist. Okay, so you got the idea?
Yes.
You let sodium go to the end, you lose potassium. If you don't take sodium out of the end, you save potassium. Because you don't force secretion.
Right.
Okay. Time safe. I think we've been up here.
So the risk would have been that I was going at if it was a potassium saving diuretic, which Lasix and thiazide are both wasting, something like hyperkalemia. But if they're potassium wasting diuretics, then you don't really have to worry about that. So this patient could be on a diuretic and an ACE inhibitor. You just might have to watch out for hypotension. Number 2. So we'll skip this one because we just went into in depth about that. And the last one was a life-threatening reaction of ACE inhibitors, but not ARBs. Yeah.
I'm not sure. I'm not sure on that one.
All right, so it's
To build up the bradykinin.
right, which causes
It's so hard, right?
Causes the angioedema.
right. So the ACE inhibitors, they would allow the buildup of bradykinin because they inhibit the enzyme that breaks it down essentially, whereas ARBs, they don't interfere with the enzyme at all. So bradykinin would be great. That's all we have.
Why do people not like to take ACE inhibitors?
Renal
Because he's ready to so they can't take it, they don't like that coffee.
There you go.
It's a good thing. Yeah, no, if you want me to move it, it's a good thing that you're. It's just
Premium. No, it's like, this is an animation,
Some of
so you
them are
click the
like-
slide and like, well, already blacked out, shows up.
I don't have the animation. It doesn't have slides.
Huh?
I said, I don't have the animation, so it doesn't have slides.
We don't know how to
We
do
can't on
animation.
Google Docs. We couldn't figure out how to do it on Google Docs.
Yeah.
All right, so how does hypertension-induced left ventricular hypertrophy affect an ECG? So we're gonna basically start at the top and work our way down in terms of the flow of logic of what is each piece and how does it affect in the next piece of the puzzle. Y'all know who we are.
Yep. So, I don't know if anybody's ever heard of the renin-angiotensin aldosterone system. However, we went ahead and put that up here, and we're going to go through it step by step and in detail. And I'm kidding, but generally, like specifically with our patient, she has stenosis that is occluding the renal artery. In which case, there's this feedback loop that's occurring that is causing hypertension systemically. But I really think we can kind of move on through this.
Y'all seen it too
Everybody
much.
fit? Is that fair?
Let's just do something real quick here.
Absolutely.
How does that stretch receptor work?
So a stretch receptor usually works because it has a portion of the receptor that is usually, I can't talk today. It has an area that if you stretch something, it's going to cause an opening of an area and or it's going to cause the movement of particular vesicles to the surface in order to have a release of their contents. Those are the two mechanisms by which most stress receptors
So what's
work.
happening with afferent arterial?
And that is,
Stretch and causing renin release.
so it actually, rather than directly causing the renin release, it's promoting the prorenin into renin, and then the renin stimulation is, that release happens posterior to that. Because we normally have the prorenin present when you have the afferent stretch and you continue down this pathway and it senses that you're having that low blood pressure from the sodium chloride side. That's going to activate that prorenin into the renin, and that stretch lets it release that renin. Is that, yes? Okay.
To the class, does everybody feel pretty well briefed on this? All right, we're gonna push on.
I'm going to hop on.
Okay. So we'll go into just basically, so why is hypertension kind of an issue? And you have a multitude of kind of long-term effects that you can see. There's a risk of, so with left ventricular hypertrophy, you're really looking at the potential of having some kind of a myocardial dysfunction. So the propagation of the electrical signal through the myocardium, there's many instances where it's going to either alter or just completely block out the proper depolarization of the ventricle altogether. In addition to that, you can have, you can pretty much reason your way through this, some kind of a congestive heart failure that can occur from the thickening of that myocardium. And then additionally, you can even have coronary artery disease that can occur either from the squeezing of the coronary arteries or just with the hypertension and all the, I'm saying vortices, but it's not vortices, the turbulence that is created in the arteries due to the hypertension. You can have thrombosis that occurs, in which case you would have for yet another added factor that would be potentially caused through ischemia and then myocardial death. You would have yet another issue with the electrical signal.
Because we're talking about Birchall's triangle here in terms of that clotting and whatnot, the endothelial dysfunction he refers to with that ischemia, that's one of the three corners of that. So you're having a huge contributor in that alone.
Absolutely. You want to head on?
Yeah, that's fine on that. Okay, so what is left ventricular hypertrophy? So this one on this side, we're looking as if we cut the body from the front. This one, we're looking straight down from the top. if you notice the healthy hearts, it's very open in the middle. It's pretty thin on the walls, but there is muscle there. It's the left ventricle. It's larger than the right because it's pumping against that higher systemic arteriolar resistance. Compared to the lung, what's the lung resistance? Lower or higher? Lower, much lower. It's extremely low compared to the systemic. When we look at this one where we have that hypertrophy, it's a very thick wall. It's an extremely high resistance system it's trying to pump against with all that high blood pressure there. So this one split down the middle, your wall you're looking at is here.
So importantly, with A, we're looking at, with A, anybody want to take a guess which type of hypertension we're dealing with? So if you see hypertrophy and your heart looks like this, and I'll give you a clue, this is the left chamber and this is the left ventricle, and this is the right. Anybody want to take a guess? Discussion. We're leading in discussion. Systemic. Very good. And then on the right, let's go ahead and point this
And
out.
our patient is due to what? What's the biggest contributor to our patient's hypertension?
Everyone knows the answer to this one.
I promise. Blood volume. Blood volume is the highest contributor. And it's because of the blood volume that you don't see going through that left kidney that we see the angiotensin II activations.
So, and then just for everyone to see, you can take a look at what right ventricular hypertrophy looks like. And what's really interesting is this is still the right ventricle here, but you can see the massive amount of dilation that's occurred. And what actually expands significantly in size is actually the trabeculae that you see. But I just thought that was really interesting to kind of show that real fast.
Come on by.
All right. So a quick review.
So what is an ECG? It's used to it's a tool we use to measure the electronic vectors present in the heart as the wave of repolarization, or rather depolarization, then repolarization moves through the heart system. Can anybody give me a brief little, what's the pathway? Where's it start? Nope.
That's the atrioventricular node. So no.
SA node
Sinoatrial node.
moves through the atricles, atrium to the AV node. Then, now when you say through the ventricles, what does it do? Depolarize first.
The left side.
The left. Well, rather in which direction is what I would like to write. Okay, but in the walls, inside the outside, and then it repolarizes in the opposite direction. That's very significant when we talk about EKGs or ECGs.
Yeah, so real fast. This part right here, anybody remember what letter we get that? D. Yeah, and this is what?
That's the QRS complex.
This is the QRS complex, and this represents the ventricular depolarization. All right. Over here we have
Depolarization.
Which is the yes.
All right, and then we don't see the atrial repolarization because it's basically hidden.
Because it's usually hidden. Where?
So P wave repolarization.
P is this early on portion.
Yeah.
So it's not atrial depolarization.
That's atrial
No,
depolarization, but repolarization. When we talk about atrial repolarization, usually the general consensus is it's hidden within the other parts because it's just not enough of a significant electrical change.
Yeah. At the same time, you're seeing the depolarization and repolarization of the ventricles, and that's just completely covering it. So
that's the long story short. That's what we wanted to dig into.
that's why we had 2 slides there. All right. So then we wanted to give a quick review of all the different leads and their placements, and then you can kind of look here and basically get an idea for if the lead direction is going that way, you can kind of guess where you're going to see a distortion in the EKG with a patient who's having left ventricular hypertrophy.
How do we get some of our angled leads? Do we literally just put them on both sides of the heart in order to figure that out, or how do we get the other angles?
Ben, you got this.
You put it on different sides. You do the vector, right?
Yeah. So it's
Yes. And with some of them, we want to have we have 2 leads. This would be example placed lower and then placed up on the shoulder, and our third one's over here, and that gives us some of the angles as well. So we don't have to have just one on both sides. If we want a different angle, sometimes we can use the summation of multiple leads in order to judge that particular vector.
So just giving a preview, you can see that you have a V1, V2 is a separate wall, V3, V4, interior wall, a lateral wall. And that's going to give you a good indication as far as the nature of the hypertrophy that's occurring in the heart.
Did you ever find where the V's were literally ventricle?
I don't know if these stands.
So the best judge of the ventricle itself are the V leads.
So the unipolar leads.
We thought possibly that could come from ventricle, but do you know anything on that? Like why the V's are okay?
Why they name it V?
We were curious if the V's came from ventricle, but we weren't able to find any
Good way
information
to
on that.
remember it.
It is a good way to remember it.
All right. So then real fast, anybody want to take a guess? So we put in a little cheat sheet right here. We're not going to make you label every single one of them.
But what are the high potency ones that you see?
Anybody want to point them out?
There's a large magnitude.
V5 and V6.
V5 and V6. And you can see that right here. So when you have the ventricular hypertrophy, the V5 is running through a significant portion of that. And V6 as well. You also see that with V4, or no, was that V4 right there?
Hop on to the next one.
Yeah. Sorry, so we have V5, V3.
I wanted to ask, why is V4 not as large as the other V leads? Anybody got a gander for that one?
The vector.
Hmm?
Is it the vector that's
So the V4
Give me a little more.
vector is right here.
The V4 vector, yeah, it's moving. So it's moving kind of between the ventricles almost in terms of directionality in the heart. But why is this V4 vector not going off the chart like these bottom four that are represented in this picture?
And we're working together here. So the V4 vector is running basically right down the middle of the heart where there's normally a large thickening of tissue, because it's essentially right where the wall of the right atria runs up against the wall of the left atria. So it's already going to be thick. So you have hypertrophy.
Anybody have ideas?
a thicker wall?
I would not agree with that one. Your statement isn't incorrect, but that's not the reasoning that the V4 is not having as large of a peak or dip. What was that? Come on, we're talking. Get some ideas. Okay, push that topic a little more. Where the vector is. Nope, I don't agree with that one. How are vectors generated? How do we read vectors? When are positive versus negative? When do we see that? It's when the negative is near the negative electrode, positive near the positive electrode, you would see a large increase and then come back down. If vice versa, you flip that, you would see a large decrease and come back up. Where is the electrical conductance in the heart? It's moving through these in a perpendicular angle. If you have that left hypertrophy, it's going to have the vector more so flat to this. If you have a perpendicular angle to the lead you're looking at, you don't see a change in the vector. It's not well read, because in terms of left and right or top and bottom of the arrow on the lead, you're not seeing a difference in the electricity surrounding those portions. Did everyone follow that? Yes, okay.
So then just finishing it up, we have multiple criteria. You can talk to a physician to ask them what their different preferences, but we put this up here. So if you add the and it's like I'll look out the screen.
Yeah.
You get the R wave,
And the
the AV, and the S wave and V3. The sum is greater than 28 millimeters. That is indicative of left ventricular hypertrophy. Different criteria for that: the R wave and AVO, and then the R wave. If the R wave is greater than 12 millimeters, by this particular criteria, that would be indicative of ventricular hypertrophy. So you can kind of see that for yourself. But generally speaking, overall, you're looking at the QRS complex and that massive expansion beyond a certain point, and that would be, if you see a patient with hypertension, it would be well within your good reasoning to administer an EKG and just make sure that there isn't some kind of left ventricular hypertrophy that's occurring. Which could definitely save the life.
And the last thing that we wanted you all to think about, would it always have to be symptomatic? If we have a patient with left ventricular hypertrophy, is it always symptomatic? No, absolutely not.
Yeah, there is plenty of room for hypertension to occur and the hypertrophy to start occurring, but you're not going to see any symptoms of stroke until something much worse happens, where you have a occlusion or you're having the electrical signal get messed up. And so that's why you can see hypertrophy on EKG, but you might not ever see it in your patient until it's too late.
That's why we usually hook people up to an ECG. It's easy to look at, it's easy to do, it doesn't cost you a lot. So where's the pain in doing it?
Yep, cheap, non-invasive procedure.
All right.
All right. Thank you all very much.
Leaving y'all with a giggle.
All right. Any questions?
Oh, they're laughing, so that's good.
I wanted to read it.
It'll be posted online.
Okay. Thanks. Oh, very interesting.
PSA, because I want to find the
Yes.
You do okay.
Have fun.
I see you, Zach. I see you moving, Zach.
Yeah, that's why we wanted to. Have to know what's in
I wouldn't be surprised.
That's why we put that in.
Right?
I mean, we had explain the results of the renal split function test. Jen, Chelsea.
So the renal split function test is a test where it looks at the function of each kidney separately, and its procedure is not very pleasant. You insert a catheter into the ureter of each one, and you collect urine. Luckily, there are other techniques now that are not as invasive. So go ahead and look at.
All right, an important thing it looks at is the GFR. I'm sure you guys remember GFR from kidney and on Wednesday. But the filtration rate, it's determined by inulin, the clearance of it. They use the classic clearance equation. Inulin is more accurate than creatinine, but you can use creatinine. They normally use that for later stage kidney failure patients because creatinine is naturally produced, and so it won't stress out the kidney like inulin potentially could. Either one is usable because they shouldn't be reabsorbed. There is some issue with creatinine, it might be reabsorbed to a small degree, but neither one is reabsorbed or secreted, so it's just filtered. A decreased GFR could indicate a decreased blood volume or a decreased blood pressure. In our case, that's what it is. When you have a stenotic vessel, you increase the blood pressure on one side of it, but you decrease it further down the line. You aren't getting the same blood volume passing through. And since the occlusion is happening before the kidney is happening, it's affecting GFR. RPF is another one that's important. It's the renal plasma flow.
Go back.
Yeah.
Use the arrow, or click on the screen and then use the arrows. Yeah.
Stenosis will lower blood volume.
Go to lower,
To the kidney. What does that mean?
since you're blocking the main artery leading into it, you're not allowing as much blood to flow through as easily. So you're effectively shrinking the size of the vessel leading in. So you're not pushing as much blood through. It's harder and harder to get it at that higher pressure. So it's seeing it as lower volume
It's lower volume of what?
of blood.
Of the artery?
Of the amount of blood getting through is decreased.
I can see low blood
Yeah.
flow.
Yeah.
But I don't quite see low blood volume.
I thought it was just a slower flow than it's
Can you look at it as a change over time and it's lower volume that passes through? As time passes, a lower volume of blood that goes through kidney.
Volume of time is flow.
Mhm.
Volume is,
I guess I
No.
feel more different with saying.
so if you took a kidney out of the body,
Yeah.
and squeezed all the blood out of it, that would be its volume, right?
Yeah.
You think the left and right kidney have different volumes,
No,
blood volumes?
it could be the flow.
So it's more about blood flow than blood volume. There might be actually a slightly lower volume of all the vessels are sort of contracted.
Yes.
From our presentation, we said that the size of the kidney is shrinking, so wouldn't that mean that it's having a lower, less volume?
The issue is more about flow than it is about volume. I just kind of wanted to make that.
Yeah. I guess we'll get that with the next one. So the next one is
Volume for time, not just static volume.
the next one is the RPF of the flow. It's the renal plasma flow. Just determines plasma. It's not the total blood flow. It doesn't include the hematocrit. You can generally assume that hematocrit is going to make up about 50%. So if you double it, you have the renal blood flow. I use PAH because it's cleared in a single pass, and like annuline, it's not going to be secreted or reabsorbed. It's an accurate way to determine blood flow to the kidney. Obviously, for a case where blood flow to the kidney is the issue, it's an important factor to look at, and it greatly impacts GFR.
So when we look at our case, this is what we were given, and we kind of made a different table just so like we could look at the overall thing. And the first part that I like to look at is the GFR and the RPF and the urine flow rate, because when I look at those values, I'm like, okay, so you're not having a lot of blood or plasma going through this kidney. So, and the purpose of the kidneys is to concentrate the urine, right? So if I don't have a lot of blood or plasma going through, I can relatively assume that my urine is going to be pretty concentrated. So that's why you see the high concentration of inulin and the PAH. Can anybody, it's kind of a question that we were wondering, but can anyone tell us why we have an increase in sodium?
Because the RAS system causes you to save sodium.
Yeah.
This normal is 20 and you're at 113 and 56.
Because of the high blood pressure that's on the right kidney, it's forcing sodium to.
I think it'd be that as much.
Yeah, so I thought of it as two ways. It's like the RAS system's causing you to save sodium, but you're not going to be able to save all of it. And if the right kidney's being, like it's sort of compensating or trying to compensate, you're not going to be able to compensate, so it's going to have a lot more sodium. I forgot where I was going with this.
You got to keep in mind too, I think the patient said she's been dealing with this for 6 years, so she's been chronically saving sodium for the past 6 years. And so that's what's causing her high blood volume. And so I don't think we ever got her blood sodium level, but you have to imagine it's incredibly high. If you're managing to take 113 out in the urine, it's going to be a pretty elevated level.
And then also, if you're having a low flow rate, that's allowing for more time for the kidney to reabsorb it too. So not only is your kidney being like, save all this sodium, now you have an overload of sodium. So it's just like, okay, there's more. Let's take more now.
Let's go back there a minute. So, normal sodium in the urine, 20 milliequivalent per liter. What is that? Why is that normal?
So when I looked that up, I was actually looking at like a relatively normal, and they said that like 20 million equivalents per liter is just like when you ask someone to go and like you analyze their urine randomly. I just need, for me, I have to have a normal to tell me, are these values really elevated or not? Can't really tell you why that's normal though.
Look at the normal osmolality of the urine. Very large range. It says 300 to 900 is normal. That's a pretty wide range. Then it says 20, your sodium is normal. You think sodium is going to be 20 when you're at 300 versus 900 milliosmoles per liter?
Yeah, probably not.
So,
I would say that 113 is probably still pretty high.
yeah.
One side.
I mean, both of them are relatively high, but I'd say 113 when one of our sources says 20 was near normal would be. It's what, 5, almost 6 times.
What's a, if you were making an isoosmotic urine that looks pretty much like plasma, what would the sodium concentration be?
I don't remember what sodium in the plasma is, but it should be.
What is sodium in the plasma?
140.
140. So if you want to say median, 140. You said 140. So if you want to say median, it'd be 140.
So the right kidney's urine is relatively low. And the left's even lower. 20 is what it could be if you were well hydrated, or you had plenty of water and you were drinking a lot of water. Kidneys didn't have much ADH in yours. But I don't know where that norm 20 comes from, but sodium has quite a much wider range than that in normal urine, just like the osmolality has a wide range.
In the blood, what I just saw is that 133 to 144 was the range in the blood.
Okay, but the range in the urine will be a lot more, lots more than 20.
40 to 220.
I thought that was pretty
Right
data.
in the urine, normal range, 40 to 220. See, what you're doing by putting up that 20 norm there is you're making a case for the right kidney to be way above normal when that might be normal. Okay. So that's one problem with that diagram. So now we've got one thing you did mention, this is important. You mentioned that flow rate's an issue. So if you have a kidney like the left kidney, which has low tubular flow, then it has plenty of time to do whatever transport it's capable of doing, and could drive the sodium quite low if sodium needs to be saved, or if aldosterone's high, which is the case here. Okay. Now the right kidney is actually overperfused. It's flowing at a higher than normal rate. There's lots of aldosterone, but at that high rate, it's hard to find all the sodium and get it out of the tubule because the flow rate's pretty fast to that tubule. Okay. So you expect the right kidney being overperfused, even in the presence of aldosterone, to have a more difficult time saving all that sodium. You expect the left kidney, which is underperfused, all the aldosterone, able to save sodium very well because the slow flow, it's a conveyor belt. Anybody watched I Love Lucy? And
Yeah, and they have like the chocolates, and that's where they work.
the conveyor belt, and she's trying to get the chocolates off the conveyor belt, and they speed up the belt, and she can't get the chocolates first, and she starts eating them and falling off the belt. It's hilarious, but it reinforces the idea of flow rate and the ability when belt rate or flow rate gets fast to find the items that you're interested in transporting or saving off the belt or out of the tubular flow. So it's pretty important. The blood flow to the two kidneys is very different, so that impacts how much blood's coming out the renal vein, what the concentration of renin is in that renal vein. If the left kidney's putting out a lot of renin and has a low blood flow, you'd expect a high renin concentration in the renal vein, like 15, but it's only 1/3 the flow of the other kidney. If the right kidney's got 4 coming out, and the left kidney's got 15 coming out, but 1/3 the blood, you could almost say that the left kidney's putting out 5 and the right kidney's putting out 4. And over time, that 5 builds up, and we get lots of aldosterone. So here's an example. I think when I was at University of Arizona, we studied desert animal kidney function. And one of the things we learned is that flow rate is really important to the function of the kidneys. For example, the length of the loop of Henle is an important issue in countercurrent exchange. So you're taking something down top and up the other side, in a sense you're exchanging across that like a heat exchanger would be. And so the length of the loop of Henle directly correlates to the kidney's ability to concentrate the urine. Yes.
Yeah, we learned about
Thank you,
that.
we were at the desert pocket mouse, we studied birds, desert quail, different things, okay? So what you'll notice is that if you have slow flow and long loops, you can concentrate the urine much more by the current exchange process and or save sodium in the collecting tubule as you do that. Desert pocket mouse has a loop of Henle relative to the flow rate through it 10 times greater than a human does. And they can produce a urine, it's 11,000 milliosmoles. We can produce a urine that's slightly more than 1,000 milliosmoles. It's all about length versus flow rate. It's real important. So when you're thinking about a kidney and what can happen in the collecting tubule or distal tubule, it's dependent on flow rate as to what can be accomplished there. And it's important to recognize that because those transporters are Lucy trying to grab chocolates out of there, and if they speed it up, she can't get them out. And they end up in the urine.
Any other question or comment?
Okay. Desert pocket mice pee crystals. Can you imagine what 11,000 milliosmol urine looks like? Yeah, looks like hay frogs.
Great series results.
Ouch. Oh, pocket mice are really little.
Do they make good pets?
Yeah.
Honestly, yeah.
Compared to body size.
There you go.
I said compared to their body size, so us versus them, oh my gosh.
Which is good if you look at what's called cortex filler length. Cortex is this much. This much.
I know.
They're saying that the brain are normal 24 hours.
But those 10 times
Typical person is 24.
That's what it's like.
You guys have to catch all in. You guys have to catch all in.
We sit out there at night, traps, and listen to the coyotes howl and complain about it.
That's not much fun.
Is this the last one?
That is correct.
You available today at 11:30?
We can go fast if you want.
No, I'm gonna stay here and I'll go when we're done. But I don't want to miss it.
We'll go real fast.
Which help? Terrible.
Alright, so our presentation was explain the treatment and post-operative results in this case. So we'll go ahead and get started. So just to point out, our patient's blood pressure was really high. It was 220/120. So they would want to manage this before the surgery and during the surgery. So they probably give antihypertensive drugs before, and then they'd also give it during an IV because anesthesia will lower your blood pressure. And then also some of the treatments, we're going to get into the graft because that's the main treatment for this. But there's also balloon angioplasty or a stent. The balloon one is down there where they'll place a balloon into the artery and just expand it to get removal of the stenosis. And then in relation, I think everyone's seen this graph, but the reason the left kidney is higher over here and it's shifted to the right is because we're having more of the isotope stay in the left kidney. So you're going to have shifting to the right and higher because of the more time the radioisotopes there. So the renal artery bypass surgery, I brought my model. So what they'll do is they'll take a graft from the saphenous vein and they'll place it between the stents, so one here and then another portion here, so the blood flow can pass the stenosis. And then we'll see in the next slide what happens to the radioisotope. But basically, they just do the surgery and move the veins there. And then they can also do it in coronary artery bypass surgery. So what happens if you look at the graph, if we look at that first, the reason we're going to have an increase right here is because most likely you just had surgery, so you're going to have increased blood flow. So there's still going to be more radioisotope going there, but it should level out over time. So we're going to see a normalization of the blood pressure and blood flow. So with renin, you should see a decrease in this renin secretion because of the increased blood flow. And with this, more salt is going to be, or sodium is going to be sensed by the macula densa. So with
say sodium chloride because
it's both of them.
We don't know. Likelihood is that, in my opinion, it's mostly chloride. Literature really hasn't caught up to it, so don't ignore the fact that the old story used to be sodium delivery to the macula densa, but putting chloride is important, and I think chloride is more important.
Okay.
I think the macula densa cells actually take up chloride, and the chloride uptake is in proportion to the thromboxane production and release. Is what stimulates renin release. So sodium chloride.
The reason for that is because with the stenosis, you'll have a lower arterial, afferent arterial pressure, and when you bypass that with the vein, you're going to increase the afferent arterial pressure, which will increase GFR and then NaCl sensing by the macula densa, and then the post-surgery we already talked about.
Okay, so we're also going to cover subsequent progress after the surgery. So I thought this was going to be mentioned earlier, but our patient has fibromuscular dysplasia. Go to the next slide. So basic overview of that is a condition that causes stenosis and aneurysm of the arteries. So you're going to get thickening of the walls, as you can see right here, which will narrow the lumen, and then you're also going to get bulging out, which that's aneurysm. And you get this look, they describe it as pearls on a string. You see it kind of there, where it just looks like different balls going down the vein or the artery, and it typically occurs in the distal portion. So symptoms of it are reduced blood flow, it can lead to high blood pressure, tissue damage due to.
You said distal portion, distal to kidney or distal to aorta?
Aorta.
Okay. So it's close to the
yeah,
kidney.
it's going to have it close to the kidney. You're going to get tissue damage due to ischemia, and rarely you can get chronic kidney failure that can lead to death. Potential treatment for this is ACE inhibitors and angiotensin II antagonists, but it's not the ideal treatment in this case.
And so we're going to ask, why would ACE inhibitors and angiotensin II receptor antagonists not be a good treatment for this?
I will point out fibromuscular dysplasia you cannot cure. So
It doesn't affect the vessel walls. The vessel walls are the issue.
What do these two drugs do? What do they treat?
ACE inhibitor is going to inhibit the angiotensin converting enzyme, which is going to take angiotensin 1 from angiotensin 2 normally, so you're going to have less angiotensin 2.
They treat the symptoms. That's the easy answer.
Okay, I was like, what?
So you want to treat the problem instead of the symptoms.
Okay.
So that's why you wouldn't want to use those.
So that's why we do surgery. So because our patient has fibromuscular dysplasia, it's going to, so it's affect the left kidney. It's going to also affect the right kidney. This happened several years later. She developed hypertension and she went back in due to the hypertension, I'm assuming. And that's when they found through this CT scan, this is her kidney, she had right kidney renal stenosis. To do that, they just did another renal artery bypass where they took her other saphenous vein.
Is the reason that the vein bypass doesn't develop the pearls or the thickening because the veins have so much less muscularity to their walls, or why would the vein not just develop the same?
No.
I think it
probably
only
just because
affects
it's artery wall.
Yeah, it just affects the artery.
Because it's fibromuscular.
Because there's just so much more muscle in the artery, the veins don't have that contributor.
When you use a vein graft like that in place of an artery, what happens to the
It'll develop more muscle,
It will.
but it still can't get to the level of an artery.
Apparently it doesn't very often do that.
Okay.
Why not bypass both of them at the same time?
She didn't have the stenosis of the right kidney yet. And I guess they didn't know it was bilateral.
Well, I mean, there, you can see it there.
Oh, this was after.
Yeah, this was several years after she had had the left.
Now, look at the left side. No bypass there.
If you did both at once and they failed, you'd be up a creek.
Pretty much it. You do them one at a time because you don't want,
If an issue
and the right
affects both.
wasn't severe enough to demand it at the time. But probably not a surprise to the people that took care of her that the right was going to do this eventually.
Gotcha.
Just based on what they saw from that arterial.
So she doesn't need more stenosis because she doesn't have any more of those veins.
When they do grafts, they replace the artery, or do they?
No,
Because
the
they
arteries-
bypass it. Okay, so in that instance, what would be the issue with doing both at once? Because if the artery's still in place, then you put them in the same condition they were previously, wouldn't you?
Well, you come in off the aorta and you go as far distal as you can get that's safe and hook it into the renal artery. So if you have a failure there, that distal end of your anastomosis, you cause the problem for the whole renal artery.
Okay, because the blood won't just travel down the renal artery?
Well, you cut into that renal artery and you made an anastomosis on the side of it. If that fails and it ends up clotting or stricturing or something,
The blood will more likely.
you buggered up the distal end of the renal artery. You don't have much left to give.
Gotcha.
Oh, that's all we had.
All right, very good.
That's it.
It'd be worth your time to look at Mr. Tolliver in terms of understanding the mechanisms and being ready for the questions that come on the final exam related to this case. Other than that, I don't have any pearls of wisdom. I guess next week, we're dealing with,
See, you can go ahead and get the last one,
endocrine
like get it
disorder.
uploaded.
All right, very good. We'll see you next week.
Thank you.